Good morning. So we are ready to continue with the next session, titled Artificial Intelligence in Action. So we are going to have three great presentations. And I anticipate that Dr. Suarez will speak in Spanish, but I'm sure it won't be a problem for all of us. Oh, great. Sorry for that. I was just given the information that you were speaking in Spanish, but that's okay. Thanks a lot. You can switch whatever you want. So our first speaker is Danilo Cimadomo, who's going to talk about automation and standardization to decrypt blastocyst morphokinetics. Thanks, Danilo.
Thanks, Maurizio. Thanks, organizer, for the invitation, and especially for having me introduced by Laura and Maurizio, that actually are the reason why I'm doing this job. There was an email 12 years ago that Maurizio sent to Laura to advise me as a new employee. So automation and standardization to decrypt blastocyst morphokinetics. These are my conflict of interest, but none of this is really going to affect the content of my talk. So let's start with the first point of the agenda, time-lapse microscopy. What is the state of the art and the rise of artificial intelligence? We know that embryo assessment can be basically made according to approaches, static or morphodynamic. Based on the static approach, we can look at the pronuclei in day one after fertilization. You can look at the number, size, and evenness of the blastomeres in day 3, if you like. And then at the blastocyst stage, you can assess the quality of the trophector and the inner cell mass and perhaps its expansion. The introduction of time-lapse basically gave us the possibility to have an observation that is not based just on little frames of this whole video, but we have a continuous observation. This means that we can make morphodynamic assessments, we can look at all the different timings and divisions, as well as we can spot abnormal cleavage patterns, as well as abnormal events such as collapse that are otherwise impossible to be analyzed. But what does this mean clinically? I mean, is this really increasing our prediction on the live birth per embryo transfer? So it is increasing really the efficiency of our assessment. Armstrong published this Cochrane review that was updated in 2019 that included 3 randomized controlled trials, and it was basically telling us that there was no increase in terms of prediction on live birth or ongoing pregnancy rate when you introduce time-lapse rather than static observation. And a few years later, Eisling also published their RCT in Livio and the Dutch group and a multi-center RCT in the Lancet confirming this evidence. But we know that the evidence is conflicting because there's also studies such as the meta-analysis by Pribensky, which is actually the first guy who reported a live birth after time-lapse culture, that instead supports the opposite. What could be the reason at the roots of these differences? Well, basically that although there is an association between time-lapse parameters and euploidy, for instance, which is the highest predictor that we have in our hands lately to assess the competence of an embryo, an association doesn't mean causation, so we cannot really rely on time-lapse parameters to assess euploidy. The studies entail different confounders. There is a list that the ESHRE released a few years ago of all the possible factors that have been associated with time-lapse parameters that are obviously different across the studies and the centers. And then even if we approach time-lapse rather than static observations, we are still subject to subjective evaluations as embryologists. And this is something that we published this year in Human Reproduction. We just shared like 500 videos of borderline blastocysts, low quality or day 7, across hundreds of embryologists part of our network. And you see by posing just the question, would you discard or keep this embryo, how discordant we are according to countries as well as within countries in making this assessment. Still, time-lapse has some advantages. That's why the reason we keep trying to find its true pros in our clinical approach. It is safe and undisturbed culture environment. Lab logistics can benefit from it. And obviously the quality of the observations. If you do science like our group is doing in pretty much all the clinics, we need this kind of data. Lately, AI rose, And obviously, it was applied at first to time-lapse video. What are, in my view, the advantages of applying artificial intelligence to time-lapse? Automation, so you see how concordant automated annotations are together with respect to manual annotation. There is an R squared of 0.92. This is quantitative, but also qualitative events such as pronuclei count, direct cleavage, fragmentation can be spotted, as well as the area of the embryo at each and any stage of development, inner area, outer area, thickness of the zona pellucida. Standardization of the assessment, rather than relying on Gardner score, Istanbul score, we can finally rely on a number, something that is quantifiable, that can be communicated, and this is extremely important in a network like ours, in which we need to discuss among countries, among centers. And then, as I said, finally we can turn qualitative information into quantitative data that you can adjust your results for, you can communicate to the patients. What did we do across the years, the last 2-3 years, trying to apply artificial intelligence to time-lapse? First thing, day 7 and low-quality blastocysts. So we know that the background related to day 7 blastocysts told us that as you move from day 5 to day 6 or day 7, there is a decrease in the euploidy rate of these embryos. Cryosurvival rate is pretty much similar, as well as the risk not to have a diagnosis when you perform PGT. But what about clinically? Well, these embryos, if you include all untested and euploid embryo transfer, they are subject to a lower implantation rate, a lower live birth rate per euploid embryo transfer, and even a slightly but yet significantly higher risk of miscarriage, even in the context of euploid embryo transfer. But they are not incompetent. So at the end of the day, TX from our colleagues in RMA published that if you include day 6 or day 7 embryos in your cohort of embryos that you're using, perhaps you might suffer a slight reduction in the efficiency of your selection per embryo transfer, but you will get more patients with at least one transferable embryo, and this can turn out in a higher efficacy. Obviously, it requires a patient-oriented decision. What are the issues of all these studies included in this meta-analysis summarized in this slide? Day 7 was defined based on day of blastulation, not really based on hours post-insemination. The embryo parameters, clinical settings, culture strategies, and local regulations were very, very heterogeneous across all the studies. So what we did is that we conducted our own study that was published in 2022, in which we included only time-lapse videos with media changeover in day 5, only PGTA at the blastocyst stage, no zona pellucida opening. So the embryo is completely enclosed in the zona pellucida until it reaches full expansion. There was no embryo deselection because we know that because of Law 40 2004, we are not allowed to deselect embryos. So any embryo was included. And there were only blastocysts, euploid single embryo transfer. We used artificial intelligence, what for? Well, basically to standardize how we call the quality of the embryo, to automate the timings, the annotation of the timings in hours post-insemination, as well as to assess the area of the embryo, as you can see here, at each and any stage across blastulation. Here you can see the distribution of the embryos according to the time of expanding blastocyst. So the first frame in which the blastocyst starts to expand, you see that it is a single Gaussian curve. Instead, the time of biopsy is 4 Gaussian. Early day 5, day 6, and day 7, because the lab is not open 24 hours a day, okay, so it's 12 hours. It's actually us choosing when an embryo should be biopsied. But with AI, we could finally assess that if you cluster the embryos every 12 hours in terms of time of biopsy, you can see that the area, when we biopsy the embryo as embryologists, it's even. So at the 5 embryo was biopsied when it was around 22 up to 24,000 square micrometers, which is the same for a day 7 embryo. So we were finally standardizing through AI what is the ideal time, the ideal expansion of an embryo to be biopsied. You see the red line there, it's the threshold for day 6, 144 hours post-insemination. You can see that above 15% of our embryos are biopsied in day 7. They come from older patients, they are of a lower quality as assessed through AI, they start expanding later, and the whole expansion process takes almost double with respect to the day 5 embryo. A lot of information that we could collect through AI and finally analyze. What about clinically? These embryos are less euploid, they result in a higher miscarriage and in a lower live birth rate. But when you adjust for confounders, specifically maternal age and quality of these embryos, there is no association with euploidy, there is no association with miscarriage, but still these embryos are less competent, so they implant a little bit less. Yet, as I said, they are not incompetent. We had 10 healthy babies out of about 40 transfers. Let's try to zoom out a little bit. If you compare just embryos that are developing before or after 144 hours post-insemination, well, you'll see that there is no association anymore. So in my view, if you're going to day 6, going to day 7 is not really affecting that much your results. We try to translate clinically this information. So what does this mean for the patients? And we did this exercise, just simulating what would have happened had we stopped culture at 144 hours post-insemination. Well, our patients would have suffered about 4% decrease in the chance of having a baby, about 14% decrease in the chance of having additional embryos to transfer after a failure, and about 5% decrease in the chance of having a second live birth after conceiving from a faster growing embryo. So at the end, day 7 embryos may represent the only chance to conceive for certain patients, a further attempt after a failure, or even a further live birth in the concept of the one and done approach. Can AI help us in saving, if you like, these embryos according to their chance of being competent? Well, as you can see in this study, we applied the IDA score as well the Chloe score. They are two different AI available, commercially available tools. You see that there is a slight association between IDA score and what the embryologists in a lab think an embryo should be discarded or not. Not that much with the Chloe. But when you compare these 50 borderline quality embryos, well, both the IDA score and the Chloe score were not performing that much in discriminating euploid from aneuploid. So we cannot still rely on it, perhaps because AI was not trained on these embryos, but trained on a priori selected databases. When we spot through the arrows those low-quality embryos that resulted in a live birth, you see that the IDA score gave a score that is around 4 or 2 for 2 of them, while the Chloe score gave almost 0 for 2 of them. So at the end of the day, we need to improve AI in order to help us understand which embryo is worth saving or not. Time-lapse thresholds. Can we define time-lapse threshold of developmental incompetence through AI and this kind of observation? We adopted a training data set of our center in Rome, over 10 years of observations. We clustered the results in these plots according to the timings, early timings of development, from the time of pronuclear appearance up to the time of 8th cell, and across to 5 maternal age ranges as the SART describes. And we produced several plots, like the one that you can see here, in which you have the curve for euploid, aneuploid, and arrested embryos. Then we applied a ROC curve analysis to define at a 95, 99, and 99.99% of significancy what embryo wouldn't become a blastocyst if it develops beyond that threshold. So, trying to define some thresholds of developmental incompetence that anyone can help, can be helped in its clinical practice. This training data set and this data were then validated in 3 further data sets, 2 internal and 1 external from Danilo Baby Bologna. When these thresholds resulted in less than 1% risk that the embryo would become a blastocyst or a euploid blastocyst beyond that, well, we called it a cutoff of developmental incompetence. So again, you see how leveraging time-lapse and artificial intelligence, we can produce clinically relevant information. Now we're moving into the deepening of blastocyst expansion evaluation. Here you see different parameters that can be spotted through AI. Inner cell mass area, inner area of the blastocyst, outer area of the blastocyst, and thickness of the zona pellucida. And we can follow this information up to the time of biopsy. Now, to even further standardize this kind of assessment according to zona pellucida area, embryo area, and zona pellucida thickness, we created what we called an expansion map, just by following these parameters for 5 hours every 30 minutes. And we built these expansion maps in which we compared how euploid versus aneuploid embryos behave and how euploid that implant versus euploid that not implant behave. We called this tool, that was actually called after a paper in RBM Online by a researcher in Honolulu, which is Tom Wang, that we are collaborating with. We call it the Quantitative Standardized Expansion Assay. Now, what's interesting is to see that already after 150 minutes from the beginning of blastulation, euploid embryos undergo a more intense and quicker thickness of their zona pellucida, and even euploid embryos that implant with respect to euploid embryos that do not implant. So perhaps, this might be an interesting further biomarker that we can try to investigate in the future. And even the expansion of the embryo that result in a live birth being euploid versus embryo that do not result in a live birth being euploid expand more and faster. And this difference gets already significant after 150 minutes. Blastocyst spontaneous collapse. This is something we published in 2022, is the event you can see there. Embryos basically are collapsing and then re-expanding. This can even be called pulsation. This is obviously an outlier embryo. It underwent 9 consecutive collapses. But what we could objectify again through AI, that it helped us spotting these events, and apparently about 50% of human blastocysts undergo at least one collapse. 1 out of 5 would undergo multiple collapses. The number of collapses and the collapse event in general is associated with the quality of the embryo, whatever you call it, Gardner or AI-based tools. It is associated with a higher degeneration rate before reaching the full expansion, a lower euploidy rate, and a slightly lower live birth rate, although it didn't turn out significant when adjusting for confounders. Last thing we're looking into that we presented at ESHRE this year, it's cytoplasmic strings in blastocysts. So these are these cytoplasmic projections that you can see in these slides intercar between the inner cell mass and the trophectoderm. We had an operator, a physical operator in our lab that was basically spotting across the 7 focal planes of an embryoscope video for each embryo, and for each frame from blastulation onwards, each cytoplasmic string, as you can see in this sequence of pictures. And he was taking notes of their presence, their number, their type. Instead, AI helped the manual annotator by including the blastocyst area in square micrometers, the timings in terms of hours post-insemination, and by also spotting the spontaneous collapses. So we put together all this information, and we came up with some interesting data, such as the ones that you can see here. Almost all patients have at least one embryo with a cytoplasmic string. 86% of embryos have at least one cytoplasmic strings. Almost 60% of them have multiple cytoplasmic strings. These strings are in place for about 4 hours, mostly in early blastulation. In 5% of cases, they are thick bridges, we call them. In 54% of cases, they are like thin threads. And in almost 40% of cases, you can see the whole process of a thick bridge that becomes a thread. Now, what does this mean clinically? Embryos that do not show any cytoplasmic string are of a poorer quality. They develop almost 5 hours later. They reach a lower expansion, 22 versus 25,000 square micrometers. They are affected from a lower euploidy rate, although this didn't turn out as significant. And then it's preliminary, but still, food for thoughts. We had 0 implantation, not even a miscarriage, 0 implantation out of 10 euploid embryos that did not show cytoplasmic strings during their blastulation. So again, this might be a further thing we would like to investigate. But the power of AI is that we can finally, turn clinical information also from a basic science perspective and invest our time in trying to understand what are these things telling us. So with this exercise of following the dynamics of cytoplasmic strings evolution and trying to see whether we can explain what's happening during the blastulation process. And here you can see we call it the tug-of-war hypothesis, in which the strings are just pulling and trying to finally locate the inner cell mass to its final position. A second hypothesis was this cell-fate commitment modulation hypothesis, in which you can easily see here in the video a trophectoderm cell that through the strings moves towards the inner cell mass and it finally joins the inner cell mass. So, another event that it's interesting to show. And the last hypothesis was this mitotic factor transport hypothesis, in which you see a trophectoderm cell in a polar position that during expansion moves towards the mural position, when technically shouldn't be mitotically active, but through the strings it keeps connection with the inner cell mass and keeps dividing. So at the end, again, we can leverage AI and time-lapse also to dig into basic science information. So what are the conclusions of these slides? We know that competence of an embryo is basically based on three concepts. Developmental competence, which is the chance that a zygote will get it to the blastocyst stage. Chromosomal competence, which is the chance that it is actually euploid. And then, reproductive competence. There still is a black box. What are the causes of implantation failure in the context of euploid blastocyst transfer? Day 7, low quality, fertilization, blastulation, cleavage abnormalities are all associated with a reduction of all these competences. And perhaps in the future, AI can finally link all these dots and, help us understanding which zygote might be a baby at the end of the story. We shouldn't be scared, in my view, about AI, because it's the same as Laura and Fauser showed in this editorial in RBM Online. In the evolution of embryo culture, the technical workload increased, but now it's decreasing because, we have AI for embryo selection, automatic annotations. But this just requires an upskilling or a reskilling of the embryologist in the lab, because the intellectual workload required is increasing, because it's us. We need to make the most out of this information. And this is why I want to thank all the collaborators in the clinics that helped us in producing these slides that I showed you. So just to conclude, Bill Gates said that we always overestimate the change that will come in the next 2 years and underestimate what's going to happen instead in the next 10, okay? So I think that AI should be judged not now, but in the next years, and we should be part of this project. I will invite you to this Congress, the Escher campus in Florence, that the SIG Antonio and the SIG I am part of is organizing, and obviously the CR Congress in March, and thanks for your attention.
Thank you, Danilo. It was a fantastic view of the future, and we will continue with this future view, calling Nikica Zaninovic from New York, who is going to talk about, can AI predict embryo ploidy? I think we are continuing looking to the future.
So we move on with our next speaker, Dr. Suarez, who's going to talk on an AI model based on endometrial ultrasound to assess pregnancy probability. Please. Thank you.
Yes,
in English.
Yes.
Sorry for that.
Just, okay, thank you. Just a minute. Well, it's a pleasure for us to participate in the symposium. Oh, sorry. That's okay. Sorry. Well, it's a pleasure for us to participate at the symposium, in particular to Mr. Andrea Borini. Thank you. I have to introduce our team because our leader is Dr. Ricardo Hash. He's from Mexico. And the other members of the team are Marlene Zamora Ramirez and Tamara Alcón. They are from Mexico too. And the other members of the team are from Argentina. Nicolás Lagua, he's with me at the symposium. And we are system engineers. So we are other professionals than you. But I have to introduce also that we are artificial intelligence researchers. we are not doctors. So we will divide our presentation in 4 steps. The first step, we will introduce our primary objective. Then we talk about our clinical research and its results. Then we present our artificial intelligence model for assessment of endometrial. And finally, we want to demonstrate the correlation between the clinical research and the outcome of the artificial intelligence model. Yes? So, we introduce an innovative approach for assessing the endometrial, and for assessing the endometrial via transvaginal ultrasound. Diverging from the previous study that concentrated on the comprehensive thickness and pattern of the endometrium, our methodology scrutinized both a relative and absolute dimension of its external layers relative to the aforementioned factors. And you should know, as absolutely your doctors, that for the blastocyst implantant, you need the blastocyst and also the endometrium. When the blastocyst reach the utero, it begins a complex interplay with the receptivity of the with the receptive endometrial lining. So we want to leave this point here, and then we will emphasize on this slide later after the presentations. Our primary objective is to introduce a fresh perspective in ultrasonographic endometrial assessment, and Billing introduced a novel classification framework that intricately elucidates its structural attributes. Okay? But by illuminating this novel viewpoint, we aim to enrich the discourse on the field. We foster a deeper understanding and contribute to the overarching goal to refine the ERT practices and optimizing the outcomes. And at the end, we will introduce our artificial intelligence model to measure the endometrial receptivity. So, starting with the clinical research, our retrospective analysis is focused only with endometrial images from individuals under the age of 45 who were undergoing ART using their own oocytes. Okay? Our exclusion criteria encompasses subjects with cervical stenosis and other embryo transfer challenges, endometriosis, adenomyosis, and phospholipid syndrome. I want to remark that this study is purely observational. Our cohort comprised 271 individuals who categorized into different treatment modalities, 241 for fresh cycles and 230 for fresh cycles, with an average age of 36 and 37 years. For both groups, the core intervention involves the transfer of 2 blastocysts, meeting the BB classification as the Gardner and Schoolcraft grading system. So, the most important thing is our timeline. Yes, the timeline indicates 4 important moments. The one where our study captured the ultrasound image is the momentum 0. Then, for fresh cycles, 7 days after the human chorionic gonadotropin administration. And for the other timeline is for frozen cycles. And the difference is that 6 days past the initiation of progesterone administration. So the last one is the pregnancy outcome. It's approximately 5 weeks for both cycles, yes? And the pregnancy outcome was ascertained through ultrasound evidence when we identify gestational sacs or embryo head motion, okay? So, taking into account this previous hypothesis, we can go for assessment the architectural attributes that we need to establish our system. We identify 6 key components. Yes? The first one is the well-defined hyperechoic external layer. We represent with the other color, we know that it's in this gray scale, but in order to represent the external layer, I represent it with the light green, yes? The thickness of the external layers, and the most important thing is the proportion of the external layer / the entry endometrium. The echogenic midline is the midline that appears in the middle of the body, and is represented with is brighter or wider. The measure of the endometrial, and the hypoechoic intermediate layer that appear that's positioned between the external layer and the midline. These six key components allow us to craft a classification schema that comprises 6 categories. The first category is that in the trilaminar configurations, we identify that the entire endometrial is equal or exceeds 7 millimeters. It's the first change of the literature. The literature always speaks with 8 millimeters, but our study is set a different point, 7 millimeters, with well-defined hyperechoic external layers, and comprising over the proportion of equal to or greater than 50% of the total endometrial thickness. This is a new concept that we are trying to expose here today. The other is the same first patterns, but accounting for less than 50%. The first is less than 7 millimeter, and we change that. We agree with that the external layer are greater than or equal to the 50% of the total endometrial thickness. The fourth is less than 7 millimeters and constituting less than 50%. The other 2 categories are related with non-trilaminar configurations. Yes, and it's related related with the displayed increasing hyperechogenicity. On the other is a high-tined hyperechogenicity. The difference between increased and high-tined is the degree of brightness that you can evaluate at the image. Yes. So, leverage this comprehensive endometrial 6 component, we presented our classification schema. But this information gives us the possibility to establish our grading system that if we can combine. That's if it's trilaminar configuration, we name the category A or B. If the endometrial thickness is greater than or equal to 7 millimeters, we say A or B categories. And related with external layer, that is our novel parameter that we are introducing in this presentation, we said that if he satisfied the condition of the proportion of external layer greater than the thickness of the total endometrium, is alpha or beta. Yes? So, in the example, we can see the different situations and all the categories impacted on each of the example. Well, we can advance with the investigation outcomes. So remember that we mentioned at the first that our cohort is 271 individuals categorized in 2 different treatment modalities, the fresh cycles and frozen cycles. Then in this table, we represent the distribution of this cohort in each of the categories that we identify. But the most important thing is when we correlate these categories with the pregnancy rate. And we identify that in the IVF for fresh cycles as well as from frozen transfer cycles, the pregnancy rate exhibit a statistical significant elevation for the group 1A alpha here, and 74% and 75%, and the pregnancy outcome for the group 1B alpha is similar than the previous, but lower, and it's still statistically superior than other categories with thinner external layers and thinner endometrial dimensions. But both of them have a good pregnancy rate. Noteworthy, the observation that patients attaining successful conception and deliveries consistently manifested an endometrial thickness of 7 millimeters or more. Yes. And we can see this feature in the categories 1A alpha and 1B alpha. So, in sharp contrast, the other groups markedly deviated with notably low success pregnancy rates are the categories identified when 1A beta and 1B beta. And remember that when we said beta is that we don't agree with the proportion of the external layer compared with to the endometrius. Okay? So, absolutely, as you know, no embryo transfer were conducted in patients liking 3-laminar configuration. Well, there is a very significant correlations between the external layers and the pregnancy rate, and as you see, at the categories 1A alpha and B alpha, when the pregnancy rates are elevated. The outcome unmistakably demonstrate the compiling correlations between the proportion of external layer compared to the thickness, total thickness endometrium, and the high tiny pregnancy rate. This connection is particularly salient in instances when the endometrial thickness is equal or greater than 7 millimeters. So, we back to the first slide, and all the previous presentations we are seeing and the symposiums is focused on the embryo analysis and the embryo analysis, embryo application of application of artificial intelligence for the embryo. But we want to focus on the importance to apply the artificial intelligence to analyze the receptivity of the endometrium. Yes, and we are convinced that if we complement the artificial intelligence methods for the embryo with artificial intelligence method for endometrium, surely we will achieve better results. Yes. So this is one of the main points that we want to express today. So at the heart of our study, significant lies the introduction of the novel parameter. No? The novel parameter is the, how the external layer contributes to the pregnancy rate. Yes, when we did ultrasonographic endometrial assessments. So the subjectivity and inter-observed variability associated with traditional evaluations underscore the need to implement artificial intelligence for endometrial assessment. Yes. Based on this, we've find at least 3 disadvantages with the traditional evaluation method. The one thing that we understand that is a disadvantage is that the sonographer mainly visually observe ultrasound images with their own eyes, see, and manually delineate the boundaries of the endometrium. And also subjective manual segmentation, because we don't have any tools. We are only seeing the screen. And all of these operations are time-consuming. Our proposal is to minimize this objective through artificial intelligence. So, the solution that we are presenting today is based on convolutional neural network to implement a 2-tier model. Why 2-tier? Because it's very important to understand that we need to segment, to focus on the endometrial trilaminar configurations, and then classify this endometrium, yes, with artificial intelligence. And we think that the model aids in accurate and efficient diagnosis. So, in the image at your left, you are seeing how the artificial intelligence focus on a particular region of interest of the endometrium and learn how to analyze the endometrium. It's very important part of the process of learning. So, why 2-step? Because, as I said previously, the segmentations isolate the region of interest, and the next step of classification label this region of interest. If you did just only classification, maybe you can make some problems related, for example, with misclassifications or reduced sensitivity and accuracy. That what are you classifying? Because as you know, the image of the ultrasound image is a very confused image, the similar color, the similar structure, but the endometrial in its trilaminar configuration is very particular. No? And we learn to the artificial intelligence to identify the endometrial in any positions in the screen. So, time finished? I quickly. So, there are some benefits of to use endometrial assessment. Just for show, you have the screen, you have to identify with our novel grading system, we identify the category, but we can abstract this. You can use manually, or if you use our endo-classify model, you can obtain the percent of good endometrium without any human intervention, yes? Just I am very quickly because they say that I have time. So let me go to the finish just for conclude, yes? It's important to say that our model is, after test a lot of different artificial intelligence models, we conclude that the best result is to use the attention unit for segmentation and then the inception Google Net for the classification. So this is an example of how is the architecture that the segmentation is at the left side, that's with encoder and decoder, with path to contracting and path to expansive, and each of these have the particular functions that allow you to segment the region of interest, and then the inception Google Net at the right is a very perfect model to classify medical images. So, just 1 minute more, please. If you see this both example, you can see that it's very similar with the subjectivity and the observer variability. No? But if you classify with our grading system, you can identify that the first is 1A alpha, but the second is 1A beta. And the difference is that the proportion of external layers don't satisfy our criteria. So, and if you evaluate these images with our endo-classified artificial intelligence model, you can see the difference, 99% Optimus and 0% Optimus. It's easy to use, and you can help avoiding to use and avoiding to measure the endometrial features. And this is just for an example. The 2A is not only trilaminar configuration. Our endo-classified model identifies 0% optimum. And this is the last slide that I need to present here. That's where demonstrate the correlation between the clinical research outcomes and the model outcomes. Because you can say at the scar plot that the most pregnancies rate successful are 1A alpha. It's correlated with the amount of good endometrios, yes? And for the another category that has high percent, you can see that there exists very good pregnancy rates too. And on the other side, it's the opposite, yes? For bad endometrios, both the model, the artificial intelligence model and the outcome clinical research coincide in the result, yes? So, I don't have any time more, sorry. I start very slowly, excuse me, sorry. But then I try to retrieve the time, but it's not, I don't retrieve the time, sorry.
Okay. Please stay on the stage. I would like to invite Nikica and Danilo to start a discussion on these very interesting topics, embryos and endometrium. Any question from the audience? Yes.
What is for Dr. Suarez, what is the variation between different cycles in the same patient? I mean, you take a measure in this cycle in this patient. You do another cycle. There is a constant imaging of the endometrium, or there is a change? I mean, this configuration for a single patient is constant, or it varies from a cycle to another?
One of the most mainly features of the AI models is the independence of the unseen images. Yes, and if you determine the right accuracy of the model, you can evaluate any image with independence of the patient. And I don't know if I am answering your question, sorry.
The question is, in the same patient,
In the
same women,
yes.
if you do it one cycle and then you repeat in another cycle, there is variability or?
No. It depends at the moment you capture the ultrasound image. The process is starting when you capture. If you intervene in another cycle, maybe...
No, but biologically, the women have always the same endometrium?
Biological, I can't answer
You
this question.
Fresh and frozen? There is a...
I don't know, sorry.
Oh, okay.
But I will ask for the medical team, and maybe I will answer your question. Sorry.
No. I have a question for Nikica in particular. I think many of us embryologists are very surprised that undisturbed culture system, just from a cultural point of view, has not really improved our results, when you look to time-lapse beside embryo selection. So I was thinking why we should have seen an improvement, but in fact, when we see randomized control trial, the undisturbed culture is not really bringing an improvement. So do you think that the fact that with time-lapse, we are obliged to use a specific carrier, a specific dish, and a specific volume of media and oil can be a limitation instead of being an upgrade? And in some condition, different volume can help more.
Danilo, cytoplasmic bridges, do they appear also in blastocysts from frozen eggs?
We didn't look into that, but I guess yes, because they are so common that I think they do apply also in frozen eggs. I really don't know if they do appear in vitrified embryos after warming. That's something that we need to check.
That's another interesting point.
Because if they are involved in the whole expansion process, it might be. If they are instead involved in inner cell mass positioning or cell-fate commitment, maybe it's more into the blastulation process rather than the expansion or re-expansion process. So I think there's a lot to investigate related to cytoplasmic strings, and now we finally have the tools to do that.
Can I continue on this topic?
Sure.
I am an old embryologist, older than you, Danilo. Many years ago, when we were seeing these bridges, especially if they were big, it was believed that it was associated with embryo splitting. Like if it would be a way that the inner cell mass could split after hatching. But now you have a completely different view on that, and it's so interesting.
The whole topic of cytoplasmic strings has been overlooked for decades. So if you look at the literature, there's most of the papers have been published in either animal models or at the very beginning of implementation of time-lapse. There's papers from Thomas Erner, for instance. Then for 10, 15 years, no one has ever looked into cytoplasmic strings. So, we're trying really to understand what do they stand for and if they can tell us something related to the embryos. In terms of logistical perspective, what we are doing in the lab is that we are biopsying embryos only after cytoplasmic strings disappear. Okay, so because they are only involved in early expansion and they disappear when the embryo is fully expanded. So at the end, it could be like a little tool to understand when an embryo can be suitable for biopsy. And
it's also a tool to understand how embryos become viable embryos. I think it's interesting to understand what we see, and time-lapse is helping for that a lot.
Okay, so if there are no more questions, I think it's time for a coffee break.
Thank you very much. Thank you, Maurizio.